Hello everyone and welcome back. This is my TED Talk and my name is Kaylee and I will be discussing pancreatitis with you. But first I want to start with a case study. We'll come back to this later in the video and it will help you remember a few things. Pay particular attention to her name and profession. We have a 42-year-old female named Christina Hobbs who's a Georgia lawyer. She has a history of partying and drinking heavily and a significant history of gallstones. She presents to the ER with severe abdominal pain that is stabbing in nature. She is also nauseous and has vomited in the waiting room. She is hypotensive and tachypnic. Labs drawn on her were amylase and lipase along with a trip to CT for cross-sectional imaging. As I talked about at the beginning of this video, pancreatitis is the acute inflammation of the pancreas. There are two types of pancreatitis, acute and chronic, which for the purposes of this video, I'll note the difference between the two of them when appropriate. According to the CDC, pancreatitis most commonly occurs in the United States and Finland. Women are more common to develop this condition with gallstones and men with alcohol. African Americans are more likely to have pancreatitis compared to whites. African American incident rate is 20 out of 100,000 cases compared to whites with only having 5 out of 100,000 cases. The two most common causes of acute pancreatitis in the United States are gallstones, which cause 35% to 40% of cases, and alcohol, which comprises up to 30 cases. Certain types of drugs have a strong correlation with pancreatitis. Some of these include valproic acids, ACE inhibitors, and mesalamine, which treats ulcerative colitis. Certain infections like mumps, hepatitis B, Coxsackie virus, cytomegalovirus can also cause pancreatitis. When patients present with chronic pancreatitis, the most common cause is ethanol abuse. Other factors to note is a history of smoking and cystic fibrosis. Now we kind of got a brief overview and understanding of what can cause pancreatitis and who develops pancreatitis. Let's dive into pathophysiology. According to Rogers, pancreatitis has an unclear pathophysiological trigger. We do know that, however, digestive enzymes within the pancreas are not secreted properly. This leads to an autodigestion and inflammation of the pancreas. Alcohol can cause acute pancreatitis through direct toxicity and immunological processes. In cases that are caused by gallstones, this leads to temporary obstruction of the pancreatic duct. With chronic pancreatitis, this is occurred by repeated acute attacks, which leads to inflammatory infiltrates and fibrosis within the pancreas. These repeated cases over time can cause the pancreas to fail. Now, after we understood how the pathophysiology works for pancreatitis, let's talk about how the patient will present. The patient should have abdominal pain in the epigastric region, which will radiate to the person's back. The person will describe the pain as sharp and oftentimes stabbing pain. This is often accompanied with nausea and vomiting. They also may appear jaundice. The patient labs might show they have leukocytosis, along with a fever. The patient also might show that they are tachypnic and tachycardic, along with being jaundice, whether it's in the eyes or in the skin. They will also show signs of abdominal distension. They may present, but it's more rare, with signs and symptoms of hypovolemic shock. Those with chronic pancreatitis are often malnourished and they have fatty stools, and they oftentimes will not show typical symptoms of acute pancreatitis. So now as a provider, we really need to dive into the patient's past medical history. This will help determine and make the correct diagnosis for this patient. Does the patient have a recurring episode of pancreatitis? Do they have hyperlipidemia or high triglyceride levels? Do they have a history of gallstones that might be causing this? We also need to look at their medications. Are they taking the medications that we talked about in the past? Alcohol is a huge problem with pancreatitis, and so addressing alcohol and CAGE questionnaire might be appropriate for the patient. The patient also might appear very confused when talking with them, and when we try to do our assessment, they're going to be like, "Don't touch me," and they're very guarded, and their abdomen might be super tight upon palpitation. We also will listen for the bowel sounds, and might more than likely be absent or hypoactive. Now that we've gotten the symptoms, we need to make the correct diagnosis for our little Christina so she can get the treatment that she needs. Um, According to Rogers on page 1356 of our textbook, as providers, we should use the Atlantic criteria when diagnosing our patient with acute pancreatitis. This is defined as the patient must have 2 out of the 3 of the criteria. This includes abdominal pain. Amylase or lipase has 3 times the upper limit of normal. One thing I want to point out in this picture is the abrupt cutoff of the gas column. This is usually indicative of acute pancreatitis. This is a CT image showing the extra fluid around the pancreas, which is also indicative of pancreatitis. Ultrasound may also be used to look for gallstones that could be causing the pain. Now you're like, okay, we made a diagnosis. Now what? We need to decide how severe this pancreatitis is going to be. So we're going to look at something called the Ranson criteria, and is this appropriate versus something called the Glasgow. The Ranson criteria is often used for those that are pointed to alcohol, and those with acute pancreatitis, we use the Glasgow Emery criteria, and this acronym is of the pancreas for this. And you're like, well, now how am I supposed to remember all this? Especially the Ranson criteria, who has 11 different criteria. So let's go back to the beginning and visit with Miss Christina Hobbs, who is the 42-year-old female who likes to party and drink. We know she's an alcoholic, so we're going to use the Ranson criteria for acute pancreatitis. On a mission, we want to look at Georgia law because she's the Georgia lawyer. Glucose, age, the LDH, the AST, and the white blood cell count. Now she's been in the hospital for 2 days, and we have to look at the C-Hobbs scale. What is her calcium, her hematocrit, her PaO2? All of those things matter. So when you look at this criteria, just think of Christina Hobbs, the Georgia lawyer. Now that we decided how severe her pancreatitis is, we need to be supportive and make her from feeling poor to feeling great again. With treatment, the cornerstone, according to Rogers, is parental nutrition, and this may often be a lactated ringer solution or a normal saline solution to reverse the hypovolemia. There's also the possibility the patient will have an NG tube that's hooked up to suction, and they'll be NPO for a period of 48 to 72 hours to make sure that they don't develop an ileus. There's evidence from up to date that points that morphine is not recommended due to the nature of the drug that can cause spasms in the ODI sphincter. And current treatment recommendation of choice is meropenem, which is when choosing a narcotic. Finally, I want to mention the use of antibiotics and the role of pancreatitis. According to up to date, the use of antibiotics should only be used if the patient is presented with signs and symptoms of multi-organ failure or sepsis. As a provider, we need to remember to treat the underlying problem. For instance, if the patient has gallstones that's causing the pancreatitis, we want to treat the gallstones. If alcohol is causing pancreatitis, we want to treat their alcohol problem so that they don't keep having recurring problems with pancreatitis. Now that we've just established how to treat this patient, we want them to have the best possible outcome. Thankfully, most cases are mild and treatable, and they often have happy endings. Other times, they do not end well. A majority of death come from multiple organ failure. Other problems may arise, such as a pseudocyst, which needs to be treated and drained, and a patient may become septic, and they may need antibiotics. The pancreas may also become necrotic, which then can lead to multi-system organ failure. Thank you for coming to my TED Talk, and I hope you guys have a great night and a great rest of the semester, and stay warm. Thank you. Bye-bye.